whoever is listening in with this. This is a briefing so that you guys on this committee, HWI, will understand the state's approach to vaccine distribution. The plan that I hope they'll tell us the plan that they've already submitted under federal law and what we're going to do differently, if anything, in Virginia, and what is going to happen as the vaccines roll out here, and what the legislature needs to do, if anything. I'm not saying we need to do anything, but we're going to listen today and educate ourselves. So, Sarah, do you want to introduce our guest speaker today?
Sure, I can do that. Mr. Chair, today we have Dr. Lillian Peek from the Department of Health. She's the state epidemiologist and director of the Office of Epidemiology, as well as the lead of the Public Health Surveillance and Guidance Work Group. And she'll be, she has a PowerPoint presentation that's been distributed to the members, and it will start up in just a moment. She'll walk you through that. Thank you.
Okay, terrific.
Well, good afternoon, Mr. Chairman and members of the committee. Thank you for the opportunity to present today on COVID-19 vaccination.
Good to see you again.
You too.
Glad you're holding up well here.
I'm hanging in there. So while the pandemic continues to evolve and we remain humble, we have come a long way since January in our understanding of COVID-19. We've learned two things through research that really have changed our response. Yeah, you can go on to the next slide. So first, a significant number of people can get infected, not have any symptoms, and spread the virus to others. This silent spread makes it impossible to contain the virus through early diagnosis and contact tracing alone. It's important to layer interventions to decrease transmission. Second, on the positive side, we've learned that face masks are protective and community masking can help slow the spread. So thankfully, as you can see on this slide, we have a number of weapons in our arsenal to fight COVID-19. And we are now, I'm happy to say, on the verge of adding another one, vaccines. It's important to understand, though, that even with an effective vaccine to protect Virginians, we will need to continue to use other strategies for quite some time. Next slide, please. In the early spring, the federal government invested heavily in 6 COVID-19 vaccine candidates. 2 of those vaccine manufacturers, Pfizer and Moderna, announced findings from their phase 3 vaccine trials. So far, both have been found to be safe and efficacious. Pfizer submitted its request to the FDA on November 20th for emergency use authorization, and we expect Moderna to do the same in the near future. So the good news is we're building on decades of experience through our public health emergency preparedness and public health vaccination programs. And we've been working since the summer to develop specific plans for COVID-19 vaccination. The vaccine will be provided in a phased approach. The supply is expected to increase over several months. So specific groups will be identified to receive the vaccine in the first 2 phases. We plan to work primarily through hospitals and pharmacy chains in the initial phase to vaccinate groups we anticipate may be prioritized, and that's healthcare workers and long-term care facility residents and staff. Vaccination will occur at clinics set up specifically for those targeted groups, and those clinics are called closed points of dispensing. So when a vaccine is approved by the FDA, we will immediately receive doses from the federal government, and that could be as early as mid-December for that Pfizer vaccine. So next slide, please. We are also building on hundreds of years of experience with vaccines. The first vaccine was developed in 1796 to protect people against smallpox. Edward Jenner observed that milkmaids who previously had caught cowpox through contact with cows did not catch smallpox. And smallpox caused much more severe symptoms and was often fatal. So Jenner showed that vaccinating people with the cowpox virus protected them against the variola virus that causes smallpox. That's the underlying principle of vaccination. Our bodies have special cells that are constantly searching for proteins, molecules that don't belong in us. And when they find them, they work to get rid of them. And they create antibodies that can recognize them in the future to act more quickly to prevent or reduce illness. Now, viruses are tricky. When they infect our cells, they not only stop them from functioning properly, but they turn them into virus production machines. Vaccines present proteins to the body that can't do that type of damage a virus can, but they can stimulate the immune system to create its own antibodies that can fight the actual virus when the body is infected with it in the future. Vaccines have reduced or eliminated many diseases that killed, severely disabled, or made people sick just a few generations ago. By identifying people who were infected, keeping them away from others while they were infectious, identifying their close contacts, and vaccination, smallpox was eradicated worldwide. In the past decade, there has been significant development in vaccine science, and that is really what made it possible to develop a COVID-19 vaccine in response to this pandemic in such record time. But vaccines have been misunderstood by some from the beginning, and this cartoon back in 1802 implied that vaccination caused people to become part cow. That's that cowpox vaccination. So we understand that, and to help us better prepare and communicate about COVID-19 vaccine, we formed an advisory work group with over 100 members from a variety of backgrounds, and they've been meeting since September 14th. They have 4 subcommittees. One is vaccine safety and efficacy, another is partnerships, a third is barriers to vaccination, and then we have a communications and messaging group. Of note, the vaccine safety and efficacy group is independently reviewing the data and studies about the vaccines that are being developed. Next slide, please. So despite some people's hesitancy about vaccination, the vast majority of Americans and Virginians want vaccination. And the demand for COVID-19 vaccine is expected to be high and initially outpace the supply. As a result, the CDC Advisory Committee on Immunization Practices, ACIP, will recommend groups to receive vaccine initially. They will base their decision on science, feasibility of implementation, and ethical principles. An example of science is the available information about the vaccine's characteristics, such as safety and efficacy in older adults. An example of feasibility of implementation is the storage and handling requirements for the vaccines. The 4 ethical principles they will use are maximize benefits and minimize harms. The allocation should maximize the benefits of vaccination to both the individual recipients as well as to the population overall. Second is to promote justice by intentionally ensuring that everyone has the opportunity to be vaccinated. And this includes removing unjust and avoidable barriers to vaccination that disproportionately affect groups that have been economically or socially marginalized. Third is to mitigate health inequities. And fourth is to promote transparency. Next slide, please. Our Virginia Unified Command has developed this process for Virginia to follow. Once the FDA approves the vaccine and ACIP recommends the priority groups, CDC will begin to allocate vaccine to states on a population basis. So that's about 2.6% of the supply for Virginia. Virginia will then adopt the ACIP recommendations. So in a parallel process, vaccine will be allocated to specific pharmacies that are participating in one of 2 federal programs. In phase 1, that's a long-term care facility partnership, and in phase 2, that's a federal pharmacy partnership. Next slide, please. So if there is sufficient amount of vaccine to cover an entire priority group, great, it'll be shipped directly to the designated vaccinators to administer. But if there's not sufficient vaccine for that entire priority group, we've laid out 2 pathways. Next slide, please. So for the initial shipments of ultra cold vaccine, which is the Pfizer vaccine, and that's what we're expecting to get first, the Virginia Hospital and Healthcare Association will provide a protocol to health systems that has been approved by the Virginia's COVID-19 Unified Command Virginia Disaster Medical Advisory Committee, VDMAC. This group was established in the spring to make decisions when they came up about scarce resources. It includes public health, healthcare, an ethicist, and a representative of the Health Equity Work Group. So in the future, if subgroups need to be identified, the vaccine unit will draft a protocol, elicit comments from the COVID-19 Vaccine Advisory Committee, and provide both to the VDMAC for the final determination. Next slide, please. As I said, we've been working since the summer to prepare, and we had a statewide seminar to provide our plan to many partners in October, early October. Our plan was submitted to CDC on October 9th. We had a statewide exercise for vaccination on October 14th. And we've been working closely with the federal government. We had an initial planning call with Operation Warp Speed, which is the name of the federal unit that's working on vaccination in early November. We are right now doing an end-to-end test of vaccine distribution with Pfizer and CDC. We'll have a technical assistance call with, we had a technical assistance call with CDC last week, and we expect to have one with Operation Warp Speed in the next couple of weeks. Our local health departments and their partners are also continuing to plan and continuing to exercise. We have regular meetings with the Region 3 federal partners. They have a vaccine task force set up. Of course, we're continuing to work through our unified command in other states, and we have regular calls with CDC and other partners. Next slide, please. So I've sort of touched a little bit on operations, and as you can see, we have to really work on some key partnerships. So we're working very closely with hospitals because we expect long-term care facilities to be a priority group early on. It's important to have close relationships with them. And then, of course, with our community providers who are going to be doing a lot of the vaccination. And as I've talked about, pharmacies will be playing a much larger role in vaccination than they have in the past. We've also been working hard to update our management information systems. CDC has developed a number of systems, and we're upgrading some of our systems so that we'll be able to have more of a streamlined approach to allocating vaccine, ordering and tracking it, to support clinic operations, including appointment scheduling and gathering all of the data and tracking all of the doses administered. Next slide, please. So this is just a little bit of a schematic to show you the flow of information. So both public health and healthcare will be reporting information on a daily basis for the vaccines that they administer. And so healthcare systems, that is through their electronic health records. And in public health, we're going to be using a new CDC system called VAMS initially. And that's going to go into our Virginia Immunization Registry, which has been in place for quite a long time. And
Dr. Peak, this is Mark. Can you, when you get to a good spot in your presentation where questions might be appropriate, if you want to pause and let people ask questions. If it's not, if you're getting to answers, keep going. But just wanted to suggest if someone had a question at this point or some other point in your talk, that you could just stop and see if there are any at that time.
Sure. Does anybody have a question now?
Mr. Chairman?
Yes. Delegate Hope, I think.
Thank you, Mr. Chairman, and thank you, Dr. Peak, for being here. You said that you indicated that you would be looking at the CDC's guidance for the rollout for who gets vaccinated, and I suppose that you're not going to deviate from that. I do want, though, to ask a question specifically about healthcare providers, how you define healthcare providers. Is it anyone that's in the healthcare industry? Is it anyone that's in the hospital? Is it for people that are in doctors' offices? And the other question that I had related to inmates in jails and prisons, people in congregate living settings, would that be part of where you have people in nursing homes and assisted living? Would you include them also in that? Because that's where a lot of the outbreaks are occurring as well.
Yes, those are two great questions. So we are using, and I think it depends on what stage we're at. So early on, the vaccine, there likely wouldn't be enough for all healthcare workers. And so that will have to be broken down into subgroups. And we're still working with VHHA to determine that. So the level to which it's broken down is going to depend on how much vaccine we have, and we don't know that yet. And so it's the same with each of the groups. We have to understand how many doses are coming, and we have in our information systems estimated numbers of people in all of these different groups, and we'll be lining that up. And so based on that, we will be doing smaller groupings if we need to. We don't really know what ACIP will recommend yet. And so before we can finalize who our groupings are and who's going to fit into what group, we'd really like to see that information. So it's a little bit hard to get into more detail yet, but we will definitely be sharing that and be very open and transparent about how we're defining these groups and who will be included in what phase, each phase.
Thank you.
Chairman?
Yes, I'm not sure. Is that Delegate Adams?
Delegate Aird.
Delegate Aird.
Thank you so much.
Too.
Yes, I have a question about the pharmacies that you referenced. You referenced CDC pharmacy partnership and the state pharmacy partnership, and I'm wondering if you can clarify if utilizing that model ensures that geographically that most pharmacies throughout the state will be covered, and if you could speak to that a bit further.
Sure. So there's two different partnerships. The first one is just with CVS and Walgreens, and they are they're working with the federal government to be able to provide vaccination in long-term care facilities. So it won't be at the pharmacy. They will be sending teams out to long-term care facilities. And we have opted in all of the pharmacies or all of the long-term care facilities in Virginia to be able to take advantage of that if they choose to. And we're still working through the details of that. But that's how the first one partnership works. And in that partnership, CDC would ship the vaccine directly to those pharmacies. And they have said that they would be looking at how to make sure that there's coverage across every state. But we would be looking at that too. And if there are any geographic areas that are left out, we would have another protocol to reach them, another strategy.
Delegate Aird, you got a follow up?
No, thank you.
Okay, I'm going down the raised hands list now. I have Delegate Adams next.
Thank you, Mr. Chair. And Dr. Peak, I was wondering if you could just tell me what is the definition of sufficient vaccination in this plan? Is it so? For example, if there are different vaccinations being developed, different storage temperatures, different protocols in terms of what if needing 2 vaccinations, when you're implementing your plan and defining it as a sufficient supply, are you including those variables?
Yes, we are. And even though we anticipate more than one vaccine, all of the information about the vaccines will be in that one information system. So that will all be pulled together. So we'll know, with information being put in the system, we'll know how many doses are available of each type of vaccine. We'll need to track who got which type of vaccine so they can get the second vaccine for their second dose if one's needed. All of that's being compiled into one system so that we can make those decisions. And that sufficient dose, we'll be looking at all of the vaccine types that we have to make, and compiling that information to use all of it.
Follow up, Mr. Chair.
Yeah, Delegate Adams.
So is there a commitment then by the state that people will not be given a vaccination that requires 2 vaccinations without that commitment of receiving both vaccinations?
Yes, the way CDC is managing at this point is that they're allocating, if it's a 2-dose vaccine like Pfizer and Moderna, if they ship the first dose, the amount for the first dose, and then that the time period later, 3 weeks later, or whatever it is, they ship the same amount for the second dose to the same site. So that is a little bit, that is different than how it was handled in the past. Even H1N1 required 2 doses for children. That wasn't done, but that is the way that CDC is allocating the vaccine at this point.
Thank you.
Thank you, Delegate Price.
Yes, thank you, Mr. Chairman. And Dr. Peak, I was wondering too, I know that work is being done on how we're defining healthcare provider, but I did have a question because I heard you say that VHHA was working with you all to help determine what that is. Are there other organizations that are working within that? Because I know that there are some frontline healthcare workers that are maybe in behavioral health or that are providing services outside of the hospital setting. And I just wanted to make sure that they were at the table as well.
We are working, and that's one of the reasons why we're working through the VDMAC that was put together to look at scarce resources. And there are other, that's a variety of people on that committee.
Thank you.
Okay. Delegate Hodges.
Thank you, Mr. Chairman. The vaccine, of course, will not get a formal approval from the FDA. It will be an emergency authorization use, and which can possibly cause some problems regarding coverage with the private plans, and then Med D and Medicare and the Medigap policies will be required to cover the vaccine. So, as far as a herd immunity, it's really going to be dependent upon the price and the coverage, especially with 2 vaccines. I've heard anywhere from $19 to $25. So, if you get 2 vaccines, $50 for, if you have a family of 4, that's $200. That can be, costly to that family, and they may not get that vaccine. Have you had any discussions with the private plans regarding coverage of, emergency authorization use vaccines?
So the vaccine is going to be free for individuals. It is free, and it's free for the providers. So the providers do not have to purchase it. It will be provided to them for free. And then for the administration fee, you are permitted to bill the third-party payers. But if they aren't able, if for whatever reason somebody doesn't have insurance or can't pay, you can't pass that on to the person. And there's federal, through the HRSA, has a fund now that providers can seek reimbursement from.
Okay. They did that to the private plans as well. I know they did that for the Med D and the Medigap and so forth, but that's as far as the private plans as well, is what you're saying.
That is my understanding.
Okay. Thank you.
Mm-hmm.
Delegate Delaney.
Thank you, Mr. Chairman. This might have been a couple of slides back as you were going through the implementation plan and the expectation of deliverables. Did you have a estimated timeline of, assuming the robust uptake that you're projecting, that you would be able to administer enough doses such that whatever is determined as herd immunity would be reached?
We do not know that yet.
Okay. Do you have follow-up, Delegate Delaney?
No, Mr. Chairman.
Okay, thank you. Okay, please continue, Dr. Peak. You're doing great.
Okay, next slide, please. Okay, so there's a lot of logistical considerations, and I think Delegate Adams was getting at some of that. There are multiple vaccines that could come about. They do have, some of them require 1 dose, some of them require 2 doses. And so there's quite a lot that we're organizing. But we have been working on this for quite some time now and working closely with CDC. So there's going to be a centralized ordering system, and that is put together by, it's run by CDC. It's called VTRAX, and that's actually what we use for our Vaccines for Children program as well. So it's not a new system to us. And CDC has expanded that to be able to use that ordering system for COVID-19. So that's awesome. For the distribution, CDC, or the federal government, has also contracted with a company called McKesson, who will be distributing the vaccine and other supplies directly for everything except, so far that we know of, except for the Pfizer vaccine. And because the Pfizer vaccine requires that ultra cold refrigeration or freezing, that will be directly distributed by Pfizer. And these distribution systems are supported by FedEx and UPS. So in our initial strategy for phase 1, based on what we know right now, and I've talked about this a little bit, we'll be using the healthcare system hub and spoke model, the CDC pharmacy partnership for long-term care facilities, and we're looking at also partnerships with other pharmacies, potentially in Virginia, that we could utilize to assist. Next slide. And this slide just lists some of the supplies that we'll be working with. It is very helpful that CDC is going to supply quite a bit of the ancillary supplies. They'll also be providing PPE, and that comes in kits that's sent out with numbers that match the amount of vaccine that's shipped. Next slide. We're also, as all states are working with CDC to pre-position the first doses of the Pfizer vaccine at health systems that have ultra cold refrigeration, and that's to shorten that first timeline between the EUA release and the initiation of vaccine administration. And VDH did work with BHHA to identify hospitals that would be able to meet this requirement. 7 health systems cover roughly 70% of Virginia acute care hospitals and include coverage in all 6 regions. And if we can work it out with CDC to ship directly to 16 facilities, that would cover 95% of health systems workforce. But again, this is only the very initial shipment. We will be looking at how to make sure there's coverage for all healthcare providers, not just those that are associated with a healthcare system.
Dr. Peak, this is Mark Sickles. I was talking to a university president, and not one of the big ones that would pop in your head, but they have a freezer system that would meet the needs. And I was wondering if you have talked to the universities to see if they could help, or you might not need them. I don't know. He brought it up.
I'm not sure. I can go back and check with our logistics. If you want to send me an information, I'm happy to make sure that we make those connections.
Okay, thanks. Thank you.
My understanding is that there are 15 different systems and I believe like 25 different facilities now. So they have already identified quite a lot of this ultra cold refrigeration. So that's been positive. You can go on to the next slide. So our local health departments are also busy preparing because first we anticipate, and this could change based on the ACIP recommendations, that a lot of the focus would be on healthcare providers and long-term care facilities. We see the local health departments playing a larger role in phase 2. So they're all working on finalizing their vaccine clinic plans to add physical distancing. They're recruiting volunteers. They're looking towards hiring contract staff. They're ordering ancillary supplies. They're preparing to receive push packs of other types of PPE that don't come with a vaccine. And they're doing a lot of training. As I said, we're using some new CDC information systems. They're also training on how to use dry ice for shipping of that ultra cold vaccine, and just looking at how to manage and administer these new vaccines. So lots of new information coming for the health departments, and we're working on getting training in place. Next slide, please. And then we're also working on a communications campaign. So we have now a comprehensive COVID-19 public information campaign. It's building off of what we had in the spring called Virginia's Health is in Our Hands, but we now have hotspot messages that go to areas where we're seeing surges. And we have prevention messages for the holidays. Hopefully you're starting to see some of this. And now, based on that overall comprehensive plan, we're developing a specific messaging around vaccination. And we're starting with extensive research so that we really understand what might be driving any hesitancy, and we can target our messages for to meet those, to answer those questions. Next slide, please. So I was thinking I was going to be sharing my screen, but since I'm not, I just want to emphasize that we do have a vaccination website up, and there is a lot of information up there. We're working with a communications company now to make it more public friendly, but we didn't want to waste any time with getting that information up. So we've had it up there for quite some time. If you go through the COVID website, there is a link to for vaccination, and you can go there to get information. We also are posting information on our advisory committee or advisory work group meetings there, so you have lots of information there. We're trying to make everything as publicly available as we can. So I'll stop there and see if you have other questions.
I see Delegate Levine has his hand up.
Thank you, Mr. Chairman. Dr. Peak, thanks for being here today. My question relates to the differences, if any, among these two, between these two vaccines and possibly a third, which I've heard may be coming down the pike. You mentioned the cold requirement for Pfizer, so that's one difference. But I'm wondering if there are any significant differences in efficacy, in side effects, contraindications, a reason why you might prefer one vaccine for one population instead of another vaccine for another population, and whether perhaps getting both vaccines is stronger than one. I'm thinking particularly about the healthcare providers that deal with COVID patients, the ones that intubate them, put them on ventilators, the ones who are most at risk. Might they get more benefit from two vaccines? So that's my question, the interplay among both of them.
Sure, those are great questions. So the two vaccines that we're looking at now are Pfizer and Moderna. Those are the ones that are coming online first, and that's because the way that they were produced is using newer technology so they're easier to make than the more old-fashioned, if you will, vaccines. So they're similar. They're similar in the way that they work. They are different. One of them, they both require 2 doses. Pfizer has to be given 21 days apart, and Moderna 28 days apart. Pfizer does require ultra cold refrigeration, and Moderna just has to be frozen. So that there's some differences in the way that they can be managed. What they've reported right now, what has been challenging during this pandemic is that a lot of scientific information has been put out in press releases. That's not great, but we understand the reasons they need to get information out quickly because it allows us to start planning. But we have not seen yet, all of the information, and it's really critical for FDA to carefully review the studies and look at the information, and then we'll have a better idea about. Then we'll feel, more comfortable with what's being reported about efficacy and safety. But what has been released so far and the preliminary studies that have been put out are very promising. And both Moderna and Pfizer have very similar efficacy. They're showing 95%. and their safety profiles were very good. So, a couple of weeks ago, I'm sorry, it's just a couple of weeks ago because I've been really busy. I went to the pharmacy very early on a weekend morning and got both my flu shot and also my shingles vaccine, and one in each arm. And I did have sore arms for 2 days, and I had a couple of days where I felt tired, but that was nothing compared to getting either of those illnesses. And so we will expect some, you do expect with vaccines, you can have some side effects like that. And that's what we're expecting with these vaccines. But what we're seeing so far is very consistent with other vaccines.
To quick follow-up, Mr. Chairman.
Yeah, Delegate Levine.
So it sounds like, other than cold storage, you really don't see, at least at this point, before you get more material from the FDA, which hopefully is coming, you don't really see a significant difference as to whether certain populations should prefer one over the other, whether it's contraindications based on other diseases or age or anything like that. You think they're functionally, I mean, you mentioned 21, 28 days, but in terms of should people prefer one over the other, it doesn't sound like there should be a preference.
At this point, these vaccines are very similar, and we don't have any information or guidance that's come out from CDC yet about them. So we will look for that, but they are very, very similar vaccines.
Thank you.
Okay, committee, we have two delegates with their hands up, and I would like to ask the clerk to be prepared to call the roll after Kathy Tran's question is answered before we might adjourn. So, Delegate Tran, the floor is yours.
Thank you so much, Mr. Chairman. Dr. Peak, I was wondering, you on the ability for us to be able to distribute the Pfizer vaccine, which has that cold storage requirement. I know you said you talked to some of our leading healthcare systems. Has there been a survey conducted of, private doctors' offices to see if they have that ability? This question on the COVID vaccine just came up for me this morning when I went to see our pediatrician. And so would love to kind of know about the ability for distributing that vaccine for some of our smaller providers.
Yeah, it's a great question. We would not expect a private provider to have ultra cold capability. I mean, they're not going to have that. So these have to be larger systems. We have local health departments are trying to order some, and so we may have some through that route. Also, though, Pfizer has created a package that it's shipped in, and it can be stored if you replenish the dry ice for a few days. So that's something that we're working on too. But we really are trying to, like I said, that first shipment to those health systems is just the very initial vaccine, and the federal government asked us to do that so that we could pre-position it and work a little more quickly. And that gives us time to understand all of the details that come out by FDA and get the rest of our systems in place. And so we will definitely be looking at how do we get it to the frontline providers. And health systems with that hub and spoke model can also get it to frontline providers.
Delegate Tran, do you have a follow-up? You look like you're thinking of a...
My wheels are turning. Thank you. Is it that obvious? Thank you, Delegate Sickles. So I think, though, my understanding of the cold storage, right, and it's not just the storage, but it's when you open it, you only have a very short window of time before you have to use all the vaccines that are provided in that, that container or whatever the technical name is. And so even with the hub and spoke model, if some of our private providers aren't well positioned to receive it and take care of it until they have enough patients to distribute that amount that they have in a very specific time frame, it sounds like some of the smaller and other types of providers outside of the big health systems might be looking at acquiring some of the other vaccines that are coming online. Is that a correct assumption?
Well, so this cooler that Pfizer's created is good for 15 days. And the vaccine can be frozen for some time, and I think it can be thawed and not reconstituted for a couple of days. So the logistics are complicated, but it still may be possible to use that vaccine for frontline providers too. So we still have to work through all of that. I mean, as you can imagine, the logistics are coming out every day since the vaccines are approved, but we're still working through that, and we're going to do everything we can to ensure that, that there is equitable distribution.
Thank you. Okay, clerk, can you please call the roll?
Yes. Delegate Rasul. Delegate Hope.
I'm here.
Okay. Delegate Price.
Here.
Delegate Levine.
Here.
Delegate Aird.
Present.
Delegate Hayes.
Here.
Delegate Adams.
Present.
Delegate Guzman. Delegate Guzman.
Present.
Delegate Delaney.
Present.
Delegate Tran.
Present.
Delegate Samira. Delegate Willett. Delegate Orrock.
Present.
Delegate Bell. Delegate Edmonds. Delegate Robinson.
Here.
Delegate Hodges.
Here.
Delegate Head.
Here.
Delegate Fowler.
Present.
Delegate Walker.
Present.
Delegate Aboli.
Present.
I'm here too.
Oh, excuse me. Delegate Sickles.
I'm here
I got you.
in the kitchen. Okay, we've got two folks left that are that have questions, and the first one is Delegate Adams.
Thank you, Mr. Chair. And Dr. Pica, I'm sure you can imagine that we're getting constituent emails already. And given the limited supply and the relative fragility of the virus, the logistics, do you see any scenario in the near future where the Department of Health will be recommending mandates around this vaccination?
No, my understanding is that that is not something that's being considered at this time.
Thank you.
Okay, Delegate Hayes, you might be the final question asker.
Thank you, Mr. Chairman. And so my question is centered around our anticipation for the need for the vaccinations and whether or not that's anticipated to be a seasonal vaccination, if you will, or will this be something that is ongoing?
That's a great question, and we won't know the answer to that until we actually have the vaccines and see how they perform and how long the immunity lasts. So we'll continue. Even the studies that are being conducted now are still ongoing. So even though they're starting to, they have enough information to begin to release the information, they will still study people who were vaccinated in the trials to see how long their immunity lasts and other information. So it's something we'll have to continue to study before we know the answers to those questions.
Follow-up question, Mr. Chairman.
Yeah, Delegate Hayes.
So my follow-up has to do with, I guess, probably all state agencies, but I'm going to just narrow it to a particular space, right? So with our colleges and universities, will they be required to follow your plan as your recommendations, or are we anticipating that the individual boards will come up with their own plans? There seems to be kind of a hodgepodge when it came to the testing, if you will.
So the plan that we're putting into place is for all of Virginia. The and part of this may be because we've had public health vaccination programs in place for a long time in the United States and in Virginia. So we already have information systems, or we had a foundation for information systems that pull all of that information together. We already have systems for shipping and distributing vaccine. So this plan is for all of Virginia, and you should see a lot of coordination and some similarity among states. There is more coordination at the federal level for vaccination than there was for testing.
So amongst our colleges here in the Commonwealth.
Delegate Hayes.
Oh, I'm sorry, Mr. Chairman, follow-ups. So with regards to our colleges and universities here in the Commonwealth, we can anticipate that they will all pretty much be following the same plan.
Yeah, I'm not could you give an example? So definitely the distribution, who's allowed, all of those things will all be the same. When we get to public vaccination, like when there's enough for anybody who wants it, I'm not sure whether colleges and universities would have different methods for getting vaccine out. But as far as how it's going to be distributed, when there's groups that are prioritized, all of that will be consistent.
Thank you, Mr. Chairman.
Thank you. So we do have a couple more questions that have arisen. We go to Patrick Hope and then back to Delegate Adams again. Delegate Hope.
Thank you, Mr. Chairman. And I did want to follow up on a point that Delegate Adams raised about mandatory vaccinations. Dr. Peak, what authority do businesses have over their employees in this regard? And the second part of that is, I would presume that in terms of mandatory requirements that we have already for children entering the public school system, that would play into effect starting next school year. Can you respond to those 2 points?
Those are great questions, and I don't have answers to them at this point. I would need to ask about policy. Businesses can create policies, and I don't know legally what that means across. I would need to research that, and we have not yet begun to talk about requirements for school vaccination and COVID-19.
Thank you, Dr. Peak.
Mr. Chairman.
Delegate Aird.
Can I piggyback off of Delegate's question?
Certainly. Help yourself.
Dr. Peak, what is the timeline for that type of discussion? I think that is a critical policy position and probably one of the most frequently asked questions from my constituents. And so I'm very curious about the timeline for trying to begin to figure that element out.
I think it's a great question, and I will bring that back to the Unified Command leadership.
Okay, but you can also send us a note too when you get the answer. We'll send it in. We will send it around to everybody. And Delegate Adams has a follow-up question.
Thank you. Yes, and that is in part why I brought that question up. So I guess the more I read about what's going on with the vaccinations, et cetera, I think we don't know how efficacious it will be over time. We presume that it will be teaching our immune systems how to respond to this virus, and that's how it will work. But with that said, we also don't know to any degree of assurance that those of us who may contract COVID-19 virus are in fact immune, and if we are, how long that immunity might last. And so the question is, again, given the limited supply, given the logistics, given all of the variables that make this sort of a difficult vaccination, do you anticipate being the policy being, so there's some data that says that you may have a prolonged boost in immunity even if you've had COVID to get the vaccination, but do you feel like we should be making that decision this early on, and do you see a state policy coming forward around that?
Great questions. Let me just clarify back with the school vaccination. So the vaccines that are coming out now, and this is typical, are going to be approved for adults. The vaccines have not yet been studied in children or other, pregnant women. So those studies still have to be done before the vaccine would be recommended for children. So that's one reason why we haven't started that planning yet around school vaccinations. But I can still bring it back for us to talk through just a general timeline. As far as whether, we don't know yet whether the recommendations will be for people who've already been infected and gotten sick from COVID and are better, of whether or not they will need to get the vaccination. So CDC, ACIP will, issue guidance, and they should be addressing that in there. And we would adopt the ACIP guidance, which, as we do for all vaccines. So it is a little bit too early to know yet how to address those questions. And, we look forward to that science and information coming out so we can make these decisions.
Thank you, Dr. Peak. And Delegate Avoli, I see you waving up there.
Yes, sir.
When you hit the participants button at the bottom of your screen, then there's a little thing called raise hand over on the side. But I saw you, though. And
Thank you.
Delegate Hayes reminded me, too, when he saw you.
Delegate Price also has a question.
Okay.
Very quickly, please, could we possibly have distributed the PowerPoint from Dr. Peak? And thank you, Dr. Peak, by the way.
Thank you so much. Sarah, that's coming, right?
The PowerPoint was distributed about an hour before the meeting, but not quite an hour before the meeting began. So you should have that in your email. If you don't, let me know, and I'll make sure you get that. It's also will shortly be available online through the General Assembly interim study page for members of the public who are looking for that.
Okay, Delegate Price.
Yes, thank you, Mr. Chairman. I just wanted to remind the members, too, that under your leadership, Mr. Chairman, we did have budget language that convened a group to study the equitable process that we'll have in making sure that all communities have access to it. And I think that report might be available today, or at least by tomorrow's deadline. And I just wanted to see, Dr. Peak, if your representatives were on there, and if you think a lot of that information was covered today. I know that it says that you'll report back monthly, but as we're talking about, prioritizing healthcare workers, definitely understand that. But then in those next steps, how we make a limited supply equitable, that's an important conversation. So I didn't know if you had anything else to add to that may be illuminated by the report that we'll be receiving.
Good question.
Yeah. Excellent question. And the COVID-19 vaccine advisory work group that I spoke of is that group. And they have been meeting since September, and that's the 4 subcommittees. And as I said, they will, so if there's an ACIP group, let's say they say, I don't know what's going to come, so I don't want to anticipate it, but just theoretically, let's say they said that the priority group was anybody who had a medical condition that put them at risk. That might be a very large number of people, and CDC may not be allocating enough vaccine for us to reach that whole group. So, that's the case where we would look at the vaccine unit, would look at the logistics of the vaccines that we have available, and then they would make a recommendation that would go to that whole advisory work group that has over 100 members, lots of diverse stakeholders, great representation. They would be giving comment. And so then the comments and our recommendations would go to the Virginia Disaster Medical Advisory Committee that does have a representative from the Health Equity Work Group and an ethicist on that committee to make the final recommendations. So we're looking for broad input and then the final recommendations from that group.
So, Dr. Peak, when you're going to put that on your VDH website, correct? Everything that comes out of that, will it be on the website?
Yes, we have a web page set up specifically for that work group, And yes, any information that, like the minutes from the meetings are on there. So yes, we will try to make that available. And I'm happy to come back and share information as we get more as we move along.
Terrific. Thank you very much. It's been very informative. Is there anybody else that wants to wave or raise their hand? I'm looking across the Commonwealth here at all my friends. Looks like we're coming to a close here. Thank you so much for carving out some time today. I know how busy you are. This is an incredible time we're living through. And so thanks again. I want to thank Sarah for all you did to get this ready, and for Alana Grinnan, my aide, who helped do this, and Roshana Senor. Roshana, thank you so much. And Jeb Benedetti and all the clerk staff that helped get this together today. So thank you very much. Take care, and we can hit your leave button now. Bye-bye.